Good evening, everyone. Welcome to Living SickleSMART. My name is Ray. I am the founder and executive director at Sickle Cell Foundation of Minnesota, and we are so pleased to bring you another session of Living SickleSMART. We are really excited. By the way, happy Sickle Cell Awareness Month. This is where we really turn up our advocacy and our efforts to ensure that there is visibility and that we are addressing the issues even more so that concern the sickle cell community. We have another very special guest for you today who is going to be coming and dropping some good knowledge on us. So we have Dominique Bulgin. She is a PhD and RN. She's an assistant professor at the College of Nursing at the University of Knoxville, and she is going to talk to us about disparities and inequities. Let me make sure that I first say special thank you to our partners and sponsors, Be the Match, Agios, Children's Minnesota, and the Sickle Cell Data Collection Program that we partner with the Minnesota Department of Health on, which is sponsored by the CDC. So we are very excited. As I said, tonight's episode of Living SickleSMART is Health Disparities and Inequities in Sickle Cell Disease with Dominique Bulgin. And if you want to learn more about, if this is your first time joining us and you want to learn more about our SickleSMART program and all of the different ways that we provide education, awareness, advocacy, leadership, patient support, visit our website. We would love for you to check us out. But I also want to let you know that in about 24 hours from now, we will upload this video to our YouTube channel, which is full of videos, educational videos from all of our events over the years that we upload it to YouTube so that it is available on demand when you need it the most. We know that every topic isn't necessarily relevant in every person's life at that time. Some of them are, though, but we want to make sure that this knowledge lives in longevity. And for whether you are a patient, a caregiver, whether you are a provider, or maybe you're an educator or other stakeholder, we want to make sure that when you need this information the most, that it's right at your fingertips. So I'm going to stop sharing. By the way, my disclaimer, we record live, so that means bloopers and all. And when they happen, and they have happened before, we keep it moving, we keep rolling. But that's okay. That's what makes this fun. And if you all know me personally, I roll with the punches and keep it going. We invite you to add your comments and questions throughout the night. If you're going to add questions, please do so using the Q&A button so your question doesn't get lost in the chat box, all right? Other than that, I think we've covered all of our bases. So now I want to introduce to you my newest friend, Dominique Bulgin. Dominique, take it away.
Thanks, Ray. Thank you all for spending the afternoon for me. Well, I'm not sure if it's afternoon for everyone, but I'm going to go ahead and share my screen. Can you see that? Okay. So as was mentioned, I am an assistant professor at the University of Tennessee, Knoxville College of Nursing. And I'm so excited to be here on this platform to discuss this important topic with you all during the month of September, no less. So the objective of this presentation is to provide a framework and just bring to light some supporting literature that exists as it relates to health disparities and inequities in sickle cell disease. And then at the end of this presentation, I'll discuss some ways that you can kind of combat and course correct some of the stigma that in inequities and disparities that folks are experiencing. Okay, so I wanted to make sure that I didn't leave people out, so I apologize if you don't need this overview on sickle cell disease, but bear with me for a few minutes. So sickle cell disease is a rare monogenetic inherited disorder of the red blood cells that primarily impacts individuals of African, South Asian, and Mediterranean descent. So in sickle cell disease, a mutated form of hemoglobin distorts the red blood cells into this sickle cell shape as opposed to this donut shape. And that causes an obstructing of the blood flow. And is the most common genetically inherited blood disorder in the United States, impacting about 100,000 people, or that's the estimate, it could be more. So another interesting thing about sickle cell disease that impacts what we'll be discussing here today is the malaria hypothesis. So it's important to note that that anywhere sickle cell disease can be found, malaria can be found, or more specifically, malaria-bearing mosquitoes. So the common denominator of sickle cell disease is proximity to these malaria-bearing mosquitoes, because having a gene or a trait for sickle cell disease is protective against some strands of malaria. So as a result, sickle cell disease is theorized to be an evolutionary response to malaria. And this is why, as I mentioned earlier, sickle cell primarily impacts people of African, South Asian, and Mediterranean descent. And you can kind of see on these graphics here, this is the propagation of malaria through Africa and South Asia. And then this is the HBS ally frequency, the sickle cell frequency. You can see how that mapping of that. So that kind of, I just want you guys to keep that in mind. So, and then briefly, I'll just say that sickle cell disease is associated with a host of serious complications, including stroke and renal failure, and anywhere blood flows, sickle cells can go. So, unfortunately, every major organ or tissue in the body is impacted by perfusion of oxygen and can be impacted by sickle cell disease. And pain is the hallmark of sickle cell disease, the hallmark symptom of sickle cell disease, and that also relates to some of what we'll discuss today. So now let's get into some definitions. So we'll primarily be talking about health disparity and health inequities today. So Healthy People 2030 defines a health disparity as a particular type of health difference that is closely linked to social, economic, and or environmental disadvantage. Health disparities adversely affect groups of people who have systematically experienced greater obstacles to health based on their racial or ethnic group, religion, socioeconomic status, gender, age, mental health, cognitive, sensory, or physical disability, sexual orientation or gender identity, geographic location, or other characteristics historically linked to discrimination and exclusion. So a recent example of how health disparities tends to play out is, of course, the COVID-19 pandemic. So at first, at the beginning, at the height of the pandemic, everyone was saying like, oh, COVID is a great equalizer, but soon, like pretty quickly, data came out that the rates of hospitalization and death were linked to social, economic, and environmental disadvantage, and that there were higher rates of infection amongst people of color, which was likely reflected due to increased exposure due to working, living, and having transportation situations that included being in closer proximity to folks. So yeah, this table from the Epic Health Research Network kind of displays, like in blue here is the hospitalization rates and the death rates. And for folks of people of color, Black, Hispanic, and Asian people of color, there were higher rates of that. So that's a clear-cut example of health disparities that is pretty, I mean, we're still going through it now. It's not even in our memories yet. So now let's talk about how this relates to sickle cell disease. So health disparities exist on multiple levels in sickle cell disease. So there are disparities in health outcomes. So health outcomes are the outcomes or results of a medical condition that directly affects the length or quality of a person's life. So the average life expectancy for most people with sickle cell disease is about 30 years shorter than people without sickle cell disease, and that's like the most severe form of sickle cell disease. People with sickle cell disease have the highest rate of returning to the hospital within 30 days of being discharged compared to people with other health conditions. And the rate of stroke in adults with sickle cell disease is 3 times higher than rates in African Americans of similar age without sickle cell disease. So those are some of the outcomes. So the outcomes here would be life expectancy, hospitalizations or hospitalization return rates, and stroke. So there's also resources and health disparities that impact sickle cell disease. So the majority of people with sickle cell disease are Medicaid beneficiaries, with less than 70% of doctors in the US accepting new Medicaid patients. So this impacts access to care. And when you have less access to care, that can lead to worse health outcomes, some of the things we discussed up here. There are also health providers may inaccurately perceive sickle cell patients as drug seeking or may doubt their experiences of pain. And as a result, this can lead to longer wait times in the emergency department, or just having to really put up with a lot more to receive pain medications when experiencing pain episodes. And then finally, the number of physicians trained and willing to treat sickle cell patients, especially adult patients, is limited. So that all of these health resource disparities are impacting access to care and can, as a result, influence the health outcomes. So you can see how that can be cyclic. So there are also disparities at the global level. So at the beginning of this presentation, I believe I described sickle cell disease as a rare condition, but this is kind of myopic with it in a US lens, because when you look worldwide, sickle cell impacts millions. So it's not exactly as rare as, we often state it to be. And the greatest burden of sickle cell disease is in sub-Saharan Africa, where access to medical care and public health strategies to decrease mortality and morbidity are not uniformly available. So both the highest prevalence and the highest mortality of sickle cell disease is in Africa, and some of the things that have allowed us to have life expectancies beyond age 5, like comprehensive newborn screening, prophylactic antibiotics, those aren't universally utilized in Africa or in African countries. So just keep that in mind in terms of just the levels of privilege and the levels of disparity that exist within sickle cell disease. So now let's define health equity. So health equity, Healthy People 2030 defines health equity as the attainment of the highest level of health for all people. Achieving health equity requires valuing everyone equally, with focus on ongoing societal efforts to address avoidable inequities, historical and contemporary injustices, and the elimination of health and healthcare disparities. So this is the Robert Wood Johnson Foundation's new image of visualizing health equity. So you can see here that everyone here has a standard bike, but it's really only working out for one person. This person is not able to use the bike at all. This person, the bike is too small for them, and then this person is too big for them. So instead of giving everyone the same, right, we want to give people what a focus on like what their specific issues are, right? So that everyone can equally be able to utilize the bike. So this is a visual example of health, of equality versus equity. So now that we've kind of talked about some of those key concepts and some of the background, let's talk about health equity and disparity in the context of sickle cell disease. So there are 3 characteristics that influence health disparities and equities in sickle cell disease. So we'll talk through all of these, but the first one we'll talk about is that sickle cell disease primarily affects Black populations in the United States. So although sickle cell disease is global and affects people of all races, as we discussed earlier, in the United States, as a result of the transatlantic slave trade and the malaria hypothesis, nearly all patients with sickle cell disease are Black. So that fact would be merely trivial, right, if we did not live in a highly racialized society. Unfortunately, the social construction of race in America requires that the majority of people with sickle cell disease not only face consequences of having this serious health condition, but they also have to navigate a society in which the color of their skin often presents an unfair disadvantage. So just to kind of define racism, author Ibram X. Kendi defines racism as a marriage of racist policies and racist ideas that produces and normalizes racial inequities. So he goes on to define racial inequity and racist policy and racial ideas. And really the idea is that we are writing these rules and creating these inequities, and people are having an equitable footing, right, based on the idea of skin color, which is not rooted in any sort of tangible science. And unfortunately, this often impacts people with sickle cell disease. So people with sickle cell often experience both interpersonal and systemic racism. And the racism that people experience is often wrapped up in stigma and ableism. So this graphic from sicklecell.org is describing a study that Carlton Haywood and his colleagues completed in 2013. And in that study, they found that Black people with sickle cell disease wait 25% longer than other people in the emergency department before receiving care. So this is a clear example of how their race is in a very unreasonable way impacting the resources and the access to care that they're receiving. And just to kind of like highlight what that experience looks like for people on a more personal level, I want to read this quote from Marcus Valentine, the co-founder of SickleCell's, and he stated, whether it's a subtle comment from a medical professional or not being prioritized in emergency rooms, when your bones feel like they're crushing because it doesn't look like you're in pain, our community is no stranger to discrimination, right? So people are having these experiences and it's baked into the system, right? And then oftentimes when folks are coming in and they're defensive already, right? We're painting them, we as in like the healthcare community are painting them as combative patients or, you know, people who are disruptive when they're responding to something that they're experiencing. And just to further exemplify how in many ways these experiences kind of operate as a microcosm that happens of things that happen on the wider society level. I just wanted to read this quote also from sickcells.org. Those who want to keep the infrastructure of police departments will react to beatings and killings by saying there are just one or two bad apples in the bunch, said Nancy Renee, a sickle cell disease advocate. When we, those impacted by sickle cell, encounter a bad sickle cell doctor, people may say the same thing. It is not the health system, just a doctor who is stressed or exhausted. This is supposed to redirect us from institutional racism that's occurring. So I just wanted to make sure that I read those quotes before I kind of talk a bit about comparisons that often happen between cystic fibrosis and sickle cell disease. So sickle cell and cystic fibrosis are similar in a lot of ways, but however, their treatment is different. And the point of these comparisons isn't to say that cystic fibrosis doesn't deserve the resources and attention that it receives, but it's just to say that things could be different, right? And because sickle cell disease isn't like diabetes and hypertension, we don't necessarily have like those sort of comparison groups to easily identify the inequities that are happening, but they do exist. And this is one of the ways that we highlight them. So cystic fibrosis and sickle cell disease are both inherited monogenetic conditions. Both have intermittent disease exacerbations that require hospitalizations. And for cystic fibrosis, that is respiratory, and for sickle cell disease, that is often pain. And both complications of both disease result in a shortened lifespan. So here are some of the differences in sickle cell disease. and CF. So sickle cell disease is 3 times as prevalent as CF, with CF affecting approximately 30,000 individuals in the United States and occurring in 1 in 2,500 white births. And sickle cell disease occurs in predominantly Black communities and about 100,000 individuals, occurring in 1 in 365 Black births. So we already kind of talked about some of these differences on the last slide, but let's look at the total funding per person affected between sickle cell disease and cystic fibrosis. So you can see here that despite cystic fibrosis affecting 1/3 fewer Americans than sickle cell disease, they receive 7 to 11 times the research funding per patient. So in this study, from 2020, so it's the most updated one. People with sickle cell disease were receiving about $943 per funding per person, whereas cystic fibrosis was receiving $10,592 per person affected. And that the outcome of that disproportionate attention and the sort of resources, that were poured in are exemplified in the treatment options that are currently available. So this orange line is sickle cell disease, and then this navy blue or black, depending on your screen, is CF. And basically, currently the FDA has approved 4 medications for sickle cell disease and 15 for cystic fibrosis. And despite sickle cell disease being one of the first described genetic diseases and having been discovered over 100 years ago, the first FDA-approved disease-modifying drug, hydroxyurea, was not approved to treat sickle cell disease until 1998. So you can kind of see that both of these conditions are extremely bad. The people that are experiencing them are suffering from like a host of complications and a lot of different issues in relation to like hospitalization. But the resources that have been poured into CF have translated to all of these different treatment options, whereas sickle cell disease, between the years 1998 to 2017, there was only that one drug, right? And we know that people's bodies are different. So that just like goes to show like, the sort of how these inequities are being translated into care and medications and treatment options for patients. So next we're going to talk about pain. So another contributor to the inequities that sickle cell experiences is it being a disease that is characterized by acute and chronic pain. So there is often a stigma from the healthcare community towards people who experience addiction. So people who have addiction to pain medication. And further, people who have pain conditions requiring treatment using opioids are sometimes stigmatized as being drug addicted, even when they are not, right? So this isn't to say that people who experience addiction or people who who require medications with opioids deserve stigma. Neither of those two groups deserve stigma, but unfortunately, all of that is sort of like wrapped up into this experience of stigma for people with sickle cell disease, even though there isn't evidence to suggest that they are experiencing drug addiction or addiction to opioids at greater rates than the general population. In fact, it's lower rates than the general population. And just to highlight how all of this is kind of propagated upon each other, we talked about systemic racism on the previous slide. And unfortunately, Black patients are often 22% less likely than white patients to receive the pain medication they need. And Black patients are often stigmatized as being drug seeking as well, even without having sickle cell disease. So despite the evidence that people with sickle cell disease have a life-threatening, lifelong pain condition that requires treatment, and despite evidence that rates of opioid addiction are low in sickle cell disease, folks are often stigmatized as drug seeking. So this study that was published in 2016 looked at the number of deaths related to opioid overdose in different populations with a specific interest in seeing how rates of overdose have increased in the general population compared to sickle cell disease since the opioid epidemic, when opioids just became a lot more accessible and led to some of the issues that we're experiencing today. And essentially what they found is that while death due to overdose in the general population has increased substantially, in sickle cell disease, it's remained pretty stagnant. And there was an update to this study, an abstract that was published in Blood in 2000. They looked at, the previous study looked between the years 1999 to 2013. And this study looked at rates between 2013 and 2019. And they compared Black populations with sickle cell disease, Black populations without sickle cell disease, and the white population. And still, rates of deaths due to overdose are remaining extremely low in sickle cell disease. So there's not that, if we're looking at overdose of opioids as a proxy for opioid addiction, it's not happening in sickle cell disease. Which, one other caveat that I will say is that even if a person with sickle cell disease is addicted to pain medications, they still have sickle cell disease, and people who have addiction deserve to be treated like human beings. But all of this is wrapped up in health-related stigma. So health-related stigma is defined as the devaluation, judgment, or social disqualification of individuals based on a health condition. And just to kind of describe this framework of health-related stigma in the context of sickle cell disease, the stigmatized condition oftentimes for people with sickle cell disease is having sickle cell. So to give an example of that, earlier I mentioned a study by Carlton Haywood, the 2013 study. So they sought to discover if individuals with sickle cell disease were experiencing longer wait times to see a physician after arriving into the emergency department. So they found that both the race of sickle cell disease patients and their status as having sickle cell disease contributed to delays. So meaning that they still had longer wait times than the general population, even after accounting for them being Black, because typically Black patients without having sickle cell disease were experiencing long wait times. So you can kind of see how the racism and the stigma related to having a pain condition, and then just stigma related to sickle cell disease status is all contributing to these health disparities. And overall, the literature surrounding stigma and sickle cell disease reveals that this stigma is not trivial. It has detrimental consequences, including stressing patients out, which causes them to experience more pain, because we do know that experiencing stressful situations increases the pain, that your pain burden. And then also just experience of stigma contribute to depression, and experiencing depression is also bad for pain and a host of other issues related to just physical and mental health. Stigma also causes patients to delay seeking care. So if you know that when you go to the to seek care that you're going to be stigmatized, that might lead you to not want to go at all. And there's just a host of issues related to stigma of sickle cell disease that are just not good for patients as a whole. So finally, let's talk about social drivers or determinants of health. So like with any other chronic illness, having sickle cell disease itself can impact individuals' ability to secure social and financial resources. And social drivers of health can alleviate or exacerbate this issue depending on what people have access to. So Healthy People 2030 defines social drivers of health as the condition and the conditions in the environment where people are born, live, learn, work, play, worship, and age that affect a wide range of health functioning and quality of life outcomes and risks. So when you look at what is causing people to have poor health outcomes, right? Oftentimes you might think it's primarily health behaviors, but the literature shows that 50% can be traced back to just your zip code, so the environment that you're living into, what you have access in terms of support, what you have access to in terms of your physical environment. Do you have sidewalks to walk, and things like that. So, and then also like your access to healthcare also impacts your, your health outcomes. So examples of social drivers of health include safe housing, transportation, and neighborhoods, racism, discrimination, and violence, education opportunities, job opportunities, and income, access to nutritious food, and opportunities for exercise, air and water quality, whether it's polluted or you live near some plant that's like releasing harmful chemicals into the environment, and language and literacy skills. So a good example of, oftentimes people think that our physical health condition is completely wrapped up in our own personal choices, right? But if you don't have access to the choices that you need to keep yourself healthy, then you don't have the opportunity to make those healthier choices. So for example, people who don't have access to grocery stores with healthy foods are less likely to have good nutrition. And that raises the risk of health conditions like heart disease, diabetes, obesity. And just as a healthcare community, right, just promoting healthy choices won't eliminate these disparities. So this is a study that was published in 2019, where Power Hayes and colleagues, they looked at they did a quality improvement initiative to screen pediatric families and children with sickle cell disease for their unmet social needs. So their social drivers of health. And what they found was that at least, or 66% of their sample was positive for at least one unmet social need, and 80% were able to be referred to some sort of like community organization that could assist them with that need. But that just shows that there is a high burden of social drivers of health, and not just people with sickle cell disease, but also families of children with sickle cell disease. And there is a need to connect people with resources and to just develop better policies surrounding sickle cell disease as a whole. And then, this is a historical example of social drivers of health. So let's take a look back into the history of sickle cell disease. So this is a quote from the book Medical Apartheid by Harriet A. Washington, in which she is describing what is commonly thought as the first discovered sickle cell patient. So in late 1904, Walter Clement Noel, a wealthy Black first-year student at the Chicago College of Dental Surgery from Grenada, was admitted to the Presbyterian Hospital. Dr. Irons, the intern that cared for him, obtained a medical history and performed routine physical, blood, and urine examinations. In the blood smear, Irons saw that Noel's blood contained many spear-shaped and elongated forms. Enraptured, Irons sketched them, suspecting that they held the key to Noel's symptoms. He also alerted cardiologist Herrick, his attending physician. Together, Herrick and Irons cared for Noel for the next 2.5 years. Noel returned to Grenada to practice dentistry, dying 9 years later at age 32. Many Blacks had been treated for severe pain and mysterious injuries of sickle cell even during slavery, but Noel's was the first case to receive such intensive attention and investigation. Perhaps because as a wealthy foreign dental student, he was a medical insider and class peer of his physician. So now let's take a look at a juxtaposing example. So in 1911, Benjamin Washburn was a medical student at the University of Virginia. And he read this article that was published about the first case of sickle cell disease. And he said, hey, I have a patient that has those same kind of blood problems. So his patient was named Ellen Anthony, and she lived in Lynchburg, Virginia. She hailed from a farm family and worked as a cook, domestic worker, and laundress when she could work, but mostly, she was sick because she had sickle cell. By 1917, she had traveled to Charlottesville to be admitted to the segregated hospital ward at least 13 times. As a Black working class woman living in the segregated South, Miss Anthony did not have access to the same opportunities as Mr. Noel, a dentist student who hailed from a wealthy family and who was often documented as the first recorded sickle cell patient. In their lifetimes, we can also see that they had disparate access to healthcare and attention from healthcare providers. So this is an age-old issue that won't be changed without active interventions to address issues related to social drivers of health. So now let's talk about things that you can do to sort of combat some of these experiences, or to combat health inequities existing in sickle cell disease. So never forget that you have the ability to impact change, and you can always leave the space a little bit better than it was before when you got there. So first, I just want to say we talked a lot about big societal issues that have been existing for centuries. So I just want to talk about the circle of concern versus the circle of influence. So the circle of concern is what you care about, and it can be everything from, you know, what's going on in outer space to, you know, what's going on in your own household, right? And your circle of influence is something that, the things that you can do something about. So what are things that you can control, or at least take actionable steps to fix? So this sort of duality between concern and influence can keep us grounded and help us not get overwhelmed when we're dealing with these big issues. So this is mainly for healthcare providers, but once you do have your circle of influence defined, you want to make sure that you're maintaining a practice of empathy. So empathy is healing, and judgment is harmful. So these are the principles of empathy, right? Empathy is healing and judgment is harmful. Vulnerable populations experience greater harm by judgment and lack of empathy. We all have judgments, and we can learn to mitigate them. So it's good, you know, as healthcare providers, to just make sure that you're keeping check of your biases and how you're feeling, right? I think on a previous slide, there was a quote about an overexhausted healthcare provider who was being stigmatizing towards patients. So make sure that as healthcare providers, there's a lot that's put on us, right? So make sure you're maintaining that practice of empathy. And then this slide is courtesy of Dr. Corella Jenneret. I definitely encourage you all to check out her work in the space of sickle cell disease and stigma as well. So you also want to consider your implicit biases and how they are impacting your provision of care, right? So just making sure that you're aware of like how your own attitudes toward a person or a thing or a group, how on a subconscious level, those are impacting your actions, even if you don't feel like they are, right? That's why it's called an implicit as opposed to an explicit bias. So I assume all pay taxes. So getting involved on a advocacy and policy level is also extremely important. And in the field of sickle cell disease, there are a couple of avenues that I know of folks who are doing that work. And one is the American Sickle Cell, or the American Society of Hematology. They have a sickle cell disease initiative, and they actually have a policy component to this initiative as well, where they're working with the White House to tackle some of the issues related to access of care. There's also the SickleCell.org. I talked a bit about them. They publish a monthly policy memo on the actions that they're taking and how, you know, individuals can get involved through signing petitions and things like that. So getting involved on your local or federal level to impact change for sickle cell disease is also extremely important. And just in terms of like a nice way to find a succinct table of things we can do to address systemic racism. This is a perspective, this table is from a perspective piece that was published in 2020 by Power, Hayes, and McGann. And they just have outlined some actionable ways that changes that can be made to hopefully reduce the impact of racism on people with sickle cell disease. So implementing universal screening for social determinants of health, reintroducing federal funding for comprehensive sickle cell centers, developing formal hospital-based reporting systems that, where, you don't just report it to avoid something happens, right? So this is a great article, and I highly encourage you all to look at it. And then some more implications for healthcare worker, being a champion and advocate for people with sickle cell disease, increasing exposure to sickle cell disease for students and future healthcare providers. So oftentimes, when you're a trainee, you're picking up your knowledge about something from people who are already in that space. So if they're hearing these negative things about people with sickle cell disease, they're just going to go ahead and propagate that in the future unless they're ever corrected. Mentoring others to become social justice advocates for sickle cell disease. And then finally, meeting individuals with sickle cell disease where they are and being what they need you to be. So sometimes folks need an ally, but sometimes people need the confidence. And this is some recommended reading that talks more broadly about issues related to systemic racism and also sickle cell disease specifically. And I hope that this presentation provided you all with a succinct overview of these issues and that you all learned something. And I just want to say thank you for listening and happy Sickle Cell Awareness Month.
That was really good. And the comprehensive approach that you took that broke down an understanding of health equity, disparities, I think that was really informative. And so once again, I just want to remind folks, if you have questions, by any means, we want you to put them in the Q&A so that we can make this an interactive discussion. I know that we have some healthcare professionals in attendance. We want to hear from you. We want to learn what others may be doing in their environments to address some of the implicit bias and some of the things that are happening in the healthcare setting. But also we know that there are individuals living with sickle cell disease who are experiencing this every day. And I've heard people talk about, a PTSD type experience that keeps them from going to the hospital when they need it the most. My own son, I am a mother of a young adult. He's 26 years old, living with sickle cell disease. And although his official transition occurred at age 21, transition is not a one-time stop. It's really a continuum that happens over time. And we started talking about it and thinking about it and processing it and planning for it well before he turned 21, but walking into there, building new relationships. I was talking to someone earlier this week, and I said, I don't think that the healthcare community recognizes the extent to what it's like to be born into, not just born into pain, but you're born into a hospitalization, a medicalization. That whereas the medical team is like an extended family. You've never known a life without them when you're a pediatric patient. So moving from pediatrics into adult care is very triggering because it can trigger feelings of abandonment. It can trigger feelings of feeling unsafe. It can trigger, feelings of mistrust that you may not have identified before because now you're building new relationships. So sometimes that distrust has to do with, historical markers throughout history. Sometimes that trust is because this is a new relationship and I don't know you and you don't know me. And we're trying to figure it out. And I might have some ideas and opinions about who you are and how you do your thing. And you might have opinions about me. So it really becomes this mutual distrust that stagnates the relationship building. So I love what you did. And in the way that you broke it down and you brought it home and that you gave solutions, you gave ways to address these issues because knowledge is power and the power to use that knowledge more intentionally, right? It doesn't happen by accident. We don't change anything by accident. We change it intentionally and with consistency and showing that we show up when it calls for us. So I think that that's amazing. Can you tell me about your work on the inside of the healthcare system, and particularly, you're in the university setting, you're speaking with, students and future physicians and individuals that will be in the medical system. What are some of the barriers that you've had to encounter as a champion for health equity?
Yeah, that's a great question. And as you were talking, it kind of gave me the perfect question to lead into my contribution. So as a assistant professor, I have the opportunity to work with students, and it's interesting to see just like the knowledge discrepancy between if we're talking at the graduate level, people who have worked in communities like St. Jude's and places where there are a ton of sickle cell disease patients, and people who have just like not had that exposure and kind of unintentionally internalize the messages that they're hearing about patients. So I would say that's a big issue. And then not even just like stigmatizing messages, there's also just a lack of knowledge. And I have a lot of colleagues that come to me and say like, hey, I am putting something together, I want to include something on sickle cell disease. Can you help me with that? Because they don't know a ton about it, because sickle cell disease, despite, being the most common rare blood disorder in the United States, it doesn't get a lot of attention in education in sickle cell. I mean, in like the medical and nursing curriculums. So that's a big issue, because then we talked about how there is a lack of providers who are willing to take on sickle cell patients. Sometimes that's just them not knowing. They don't feel comfortable treating something that they're not that familiar with. And they're like, oh, I know you need a primary care provider, but maybe you can just get some of that taken care of with your hematologist. And, they're not as savvy on the ins and outs of taking care of people with sickle cell disease. So I would say that's a huge issue. That's definitely something that, develop actionable steps to address.
Yeah, and I think it's important that we don't put every medical provider, just like law enforcement officer, into the same bucket. I really like that you included that comment that you found through SickleCell, because there's these comparisons, because we're talking about systems, right? These are systems that when they were initially built, were not built for us. And in fact, we weren't the only ones they weren't built for. We have to really look at history and unpack the realities of some of the uglier parts of America. And so when these systems started, there were groups, and certainly we can call out the group Blacks who were not allowed within the walls of these systems. And so whether it was an education system that was developing, whether it was a healthcare system that was developing, we can see where they have had to adapt to allow us, but they may not have adapted to accept us, right? And so as we begin to have really thoughtful conversations with individuals that influence power within these structures, I think that it's very important that we provide a various lenses through which to see this issue, as well as the various approaches that it takes. I want to make sure that we're celebrating all of these physicians who are out there who are doing a great job at caring for sickle cell disease. Many, I would consider them physician advocates in the same way that I look at patient advocates. They are within the walls of their institution. I spent many years working on the inside of healthcare as part of the pediatric sickle cell team. And I can tell you that it's not always to speak up unapologetically in the midst of these policies that are built in such a way that you know, it is embedded within the way that medicine is approached, that can actually exacerbate some of these statistics that you showed, the social determinants of health and the influence of social determinants of health, but also understanding a community that has been plagued by disparities that impact how we utilize systems or at what point we enter into systems, right? So there's so much rich discussion that we can have if we get past what makes us all so different. I always think we should start by leveling the playing field and talking about all the things that we have in common, right? As a caregiver, you know, if I go with my adult son to the emergency room, and they're wondering why I may speak on his behalf at times, you know, I think about the fact that if these individuals had a child who was in a dire medical situation and could not mentally, emotionally, physically even speak for themselves, they're not in a great state of mind living in that much pain, that representation and that level of advocacy by being able to speak on their behalf because we have a relationship is critically important. And I'm convinced that medical professionals sitting in front of me would do the same for their child, would do the same for their parent, their loved one, in order to make sure that they receive the outcome that they needed to preserve their life and to ensure that they could go on with a quality of life. So having these discussions, although sometimes it feels uncomfortable and it feels like these are really difficult topics to have and they stir up lots of emotions, you know, to not have these conversations means, you know, that we're not addressing the stigma. Right? Not having these conversations is part of the stigma or the weight of the disparities and the mistreatment, undertreatment, no treatment. The weight of that, you know, makes it difficult to talk about on all sides of the table. So I'm so proud of all that you do in the space that you're in, and we have to continue to link arms. When we say community at Sickle Cell Foundation of Minnesota, of course, we're talking about individuals living with sickle cell disease as well as their caregivers. But we also operate off of a in the house, out of the house kind of mentality. And we believe that it's important to include those who really have a vested interest in the positive and improved outcomes of this community to be considered as part of the community. That way you're not standing on the outside of our house looking in saying, well, what do we need to do for them? You're on the inside of the house with us. And instead that response is, what do we need to do for us? Right? That elicits an entirely different response because now it's personalized and we can apply actionable steps because we benefit individually, whether you're the patient, the caregiver, the medical provider, even the educator. That's what we seek to do. So we have to normalize these types of conversations and bring people into the conversation. When I first met you, we were doing nurse training, right, on sickle cell nurses, and it was amazing to watch just the growth of even individual nurses who they came because they want to do the right thing, but they were still learning about the community. They were learning about those interactions. Can you talk a little bit more about the importance of training sickle cell nurses? Because you are an RN. Can you talk more about the value of training nurses, doctors, those who will impact outcomes in the sickle cell community?
Yeah. So there's so many levels to that. So this, as you alluded to, this summer, we had the opportunity to put together the first ever nursing care of sickle cell disease boot camp. So we've been working for over a year now on this curriculum of nursing care of sickle cell disease, just to, you know, because we can talk all day back and forth about how, you know, training nurses is more important, providing access to, or just having more education resources. If they aren't there, then people won't be able to utilize them. So that is, I'm, you know, so happy to have been included in that initiative. And I think that's going to be great globally as well, because if we're able to develop a curriculum, it can be transferred depending on the setting.
Yeah.
I also just wanted to highlight an example of just the sort of advocacy that happens within the sickle cell community during the opioid epidemic, when they were creating new policies surrounding mandating what patient populations could have access to opioids. Just by sheer oversight, sickle cell was left out of it, and the physicians and nurses and healthcare providers spoke up and was like, you need to include sickle cell, not just cancer patients, as a population that is an exception to these new rules you're creating surrounding opioid use. So there's just so many people who are champions in this space. And, you know, while I wish there was more, but you know, I think there's so many people who are champions. And I've talked to providers who were working at one hospital in a space where they got sickle cell patients, but they didn't necessarily have any champions there, and they just treated them in the ED and then moved on. And then, you know, coming to a space that has like a comprehensive care setting, it was just night and day for them, and they could see the tangible outcomes, the better outcomes that patients were experiencing, just to show how myopic their prior approach was. So yeah, I think yeah,
you know, the value is immense. And, you know, whether you're a patient caregiver, whether you're a patient advocate, whether you are a medical provider or in the medical space, I challenge you, you know, much like the approach that the United States took with terrorism and all of those things. The goal is see something, say something, right? And if your hospital or clinic or setting that you're in does not have a method for reporting, you know, maybe it's a lack of dignity and respect. But if they don't have a mechanism for reporting that, maybe that's something that you can invest your time in, and in helping them to process ways that they can better provide an opportunity for people to report what they might have seen, not just what they've experienced, because a lot of times people are on the sidelines, and we want to get you off the sidelines and we want to bring you in the house, right? We want you to be part of our community. You don't have to live with sickle cell disease to be part of this community. You don't have to be a doctor. You just have to, as our medical director says, you just have to give a damn. We just need the people who give a damn to actually speak up, come in the house, become part of this bigger community. So before we wrap up, I know I'm looking at the hour now. I just want to make sure that we get all of the rest of our slides out. Again, I want to say thank you to Dr. Dominique Bulgin. I'm so excited about the trajectory of your career and your studies and all that you do. We have added her email, dbulgin@UTK. What does that stand for?
University of Tennessee, Knoxville.
That's right, University of Tennessee, Knoxville.edu. And you can find Miss Dominique on LinkedIn as well. Just a reminder, we've had some really great SickleSMART sessions this month. We kicked it off with our East meets West caregiver perspectives. We were talking about the African experience, the migration experience, the immigration experience, the cultural experiences between a mother who is caring for her son with sickle cell disease, being born and raised in sub-Saharan Africa, and then moving to Canada. Now she is the president of the Sickle Cell Disease Association of Canada. And myself, as a mother born and raised here in the Midwest, raising my son with sickle cell disease, and our experiences that brought us to where we are, with us both being over community-based organizations. You don't want to miss that. In fact, you may not get through the whole thing because it was the longest SickleSMART session we had ever done, 2 hours, and no one left. That's how robust that conversation was. But it was great. Biba and I could talk forever. We're like, we have to stop talking, Biba. So it was good. The other one that we did, and that was just earlier this week, we did a natural wellness with our special guest, Dr. Charlie Ware. He's a holistic medicine physician, and he has brought an amazing expertise into the sickle cell community that really revolves around what are we putting in our body? How are we utilizing our body to promote our health? And so once again, you can view our previous episodes by going to our YouTube channel. We invite you to make sure that you sign up, click the little, what is that, a bell that you can click so that you'll be notified whenever we upload new content, but you can also sign up to be a subscriber on our Eventbrite channel, and you will get that information as well. We never close out a show without reminding our audience that we are in a severe blood shortage, and it absolutely impacts individuals living with sickle cell disease. The blood shortage is across the board. But as with so many other things, there's a disparity in who it's impacting the most. One of those reasons we can actually do something about, okay? Our blood saves lives. The importance of the diversity of blood donors can make the difference between having that unit available for someone who may be facing life or death complications and someone who doesn't have access. And so even if you're a physician, even if you're a medical provider in the medical space, I encourage you to use your voice. Talk to the families that come in about how they can utilize their lived experience within their community to encourage people to donate blood. So if you really want to lend a hand, what does it say? Lend an arm. And if you want to learn more about why Black blood matters, we did do a session several months ago about diversifying the blood donor pool, and you can find that on our YouTube channel as well. Of course, we're going to talk about joining Be the Match. There is a cure available for sickle cell disease. It is not a universal cure, and not all qualify for it. But for those who do, again, the disparity of not having enough diversity in the registry means that they may not find the best match, whether it's blood or it's bone marrow, to transfuse or utilize anything less than the best match can be life or death, and it can increase morbidity. So listen, if we are the cure, I want to remind you, we is the we. We are the we. We are the cure. So we have to participate. We can't just talk about it. We got to be about it. What I love is that Be the Match has put, their advocacy to action. They actually have a sickle cell resource package. It is free. If you are a person living with or caring for someone with sickle cell disease, you love someone with sickle cell disease, you can go online to www.sicklecellconnect.com and you can order your packet. But if you're a provider, you can tell your patients about it so that they too can get access to this information as well. Our monthly virtual activities, that means they are open to the public. Y'all join us. Of course, we have our Living Sickle Smart because you're here and you've joined us, but we also do a cooking class every month that focuses on adding anti-inflammatory foods to your everyday meals. You don't have to have sickle cell to know that inflammatory foods are everywhere. I have sickle cell trait, and related or not, when I eat certain foods, my knees hurt, my joints ache, because I've learned over the years how to listen to my body a little bit better. and recognizing that sometimes it's the food choices, but oftentimes it's the food that's in front of us too. And so again, that goes back to, other social determinants of health, as you mentioned earlier. We have a monthly support group that is for ages 16 and up. So we invite you, young adults and other adults. We want you to come. It's really about empowering you. Yes, we talk about the difficult stuff, but we're determined that we don't walk away from that meeting without also talking about solutions. If you know Ray is solution oriented. We have to be part of that solution. And then if you are local and you need school supplies, we now have a year-round program that assists with school supplies. We give coaching around education plans. We provide nurse education that complements what the clinics bring. And then we know that it's really difficult to learn on an empty stomach, and many kids are still dealing with food insecurity. But also, we have micro grants for those who are in college that helps to purchase books and supplements other needs. And then, of course, our Sickle Celebration of Hope, which is coming up on Friday, September 23rd. We're so excited. You can go online on Eventbrite and purchase your tickets again if you're local. Now, if you want to fly in, if you want to come in and visit, it's not quite winter yet here. So for those of you in those sunny states, you don't have to be afraid to come to Minnesota. Last but not least, I want to inform all of you about a new program that we started earlier this year, Our Voices Matter. It is a multifaceted approach to using our voice for the good, making sure our voice is heard, helping people to understand how to tell their story. And this is not just about sharing negative medical experiences. We want to hear positive experiences just as much as we want to hear your negative experience. Like I said, we want to celebrate the medical system, those in the medical system who are doing well, but we also want to identify where there may be patterns in other institutions or in individuals, so that as we at Sickle Cell Foundation of Minnesota are sitting at tables of influence, we have concrete examples of what's maybe happening in their institution and across the sickle cell community. So you do not have to be in Minnesota to utilize the Our Voices Matter platform, but we do invite you to help us make a difference. We are grateful to our supporters. Once again, please support our supporters, Agios and the Rise Up study, Children's Minnesota and their sickle cell disease comprehensive clinic that they have had for many, many, many years. Be the Match, as I mentioned before. And then, of course, the sickle cell disease data collection program here in Minnesota that is funded through the CDC. All right, did I get it all in? I do believe so. Dominique, thank you for being our special guest tonight. We really appreciate you sharing your knowledge, your expertise, and your experiences with us. It is Sickle Cell Awareness Month, so I challenge each of you to go out and be a sickle cell champion in the spaces that you are in. And thank you for coming. We'll see you next time. Bye-bye.
Bye, everyone. Thanks for coming.